Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who is interested to attend. Today, we will be discussing updated COVID-19 guidance that relates to nursing homes. Everyone has been entered into the meeting on mute, but we will have a discussion at the end of this webinar. So if you have questions or comments, please submit them to us using either the chat or the Q&A tool in your Zoom menu. We encourage you to join us every Wednesday at 2 p.m. for more of our weekly webinars in this series. Next week, we'll be discussing emergency preparedness planning for nursing homes. My name is Kathy Caudill. I'm a communication specialist with Quality Insights. And now I would like to introduce our guest today, Jennifer Brown. Jennifer is a quality improvement and infection preventionist at Quality Insights. She is a registered nurse with over 10 years of experience in a variety of healthcare settings, most recently as Director of Staff Development and Infection Prevention in long-term care. She has also led several quality improvement and infection control initiatives in acute and ambulatory settings. So Jennifer, welcome back, and thank you for joining us today. And you have your presentation up there on the screen. So when you're ready, you can take it away.
Thank you so much. Good afternoon. My name is Jennifer Brown, and today we will go over some updated guidance from the CDC and also from CMS regarding COVID-19 updates. So there have been some updated guidance surrounding source control for visitors and staff, vaccination status, which is no longer used to determine source control, screening, testing, or post-exposure recommendations. Also, routine testing of asymptomatic staff is no longer recommended. Quarantine and work restrictions for exposures are generally no longer recommended. And there's been updated testing recommendations for asymptomatic patients and residents and healthcare personnel. Also, updated testing recommendations for those who have recovered from COVID-19. So there are some guidance that will stay the same. The time frame for isolation for both residents and healthcare personnel will continue to be the same. Symptomatic individuals will still need to be tested, and also the use of PPE for suspected or confirmed COVID-19 is still recommended. The Pennsylvania Health Alert Network guidance has also been updated to reflect these changes. So the PA-HON 621 has been replaced with PA-HON 661, which covers work restrictions for healthcare personnel with exposure to COVID-19. PA-HON 622 has been replaced with PA-HON 662, which covers return to work for healthcare personnel with confirmed or suspected COVID-19. And PA-HONs 624, 626, and 627 have been replaced with PA-HON 663, which covers infection prevention and control recommendations for healthcare settings during the COVID-19 pandemic. There is no longer a separate HON for nursing home recommendations. Nursing home recommendations have been added to the HON for healthcare settings, and there's a section addressing nursing home under that HON. So the first major change that we'll discuss today is regarding source control and universal PPE. Source control recommendations are based on community transmission, not community levels. Vaccination status no longer used to determine if source control is to be used. And in areas where community transmission is high, everyone in the facility should wear source control, such as face masks or a respirator, and to cover their mouth and nose. In areas where community transmission is not high, healthcare providers can choose not to wear source control in non-resident care areas, unless there's an outbreak, in which case source control is required. Source control is still recommended for individuals who have suspected or confirmed COVID-19 infection, or if they have had an exposure to someone with COVID-19. Facilities located in counties with high community transmission should also consider having healthcare providers use universal PPE for all aerosol generating procedures, all surgical procedures that might pose a higher risk for transmission if the patient has a COVID infection, and in specific units or area of the facility at higher risk for COVID transmission. Universal PPE includes N95 respirator and eye protection, such as goggles or face shield that covers the sides of the face and the front of the face, which should be worn during all patient care encounters. The next major change in guidance surrounds screening testing, which is no longer recommended for nursing home healthcare personnel if they are asymptomatic and not had a recognized exposure. There have been some changes in recommendation for exposures to COVID-19, and under the new guidance, asymptomatic healthcare personnel do not require work restriction after a higher risk exposure, regardless of their vaccination status. Per the CDC, a high-risk exposure is any prolonged close contact with a resident, visitor, or another healthcare provider with a confirmed COVID infection where the healthcare provider was not using a respirator, was not wearing eye protection, or was not wearing all recommended PPE while in the room for an aerosol generating procedure. Asymptomatic individuals, regardless of their vaccination status, should be tested following exposure. The first test should take place on day 1 after exposure. So this test should take place immediately, but not less than 24 hours from the exposure. The exposure date is considered day 0. If the test is negative on day 1, they should test again in 48 hours, which would be day 3 post-exposure. And if the second test is negative, then they should test again in 48 hours, which would be day 5 post-exposure. Testing is not recommended for asymptomatic individuals who have recovered in the past 30 days, which it was previously recommended as 90, but it's been shortened to 30. If the individual develops any symptoms at any point, even within that 30 days post-infection, they should be tested. An antigen test is recommended for individuals who have recovered from COVID-19 in the past 90 days. Quarantine is no longer routinely recommended if the individual is asymptomatic, regardless of their vaccination status. Any individual who has had an exposure should monitor for symptoms. They should be tested on days 1, 3, and 5, and use source control for the 10 days following their exposure. In the event your facility receives a new admission, new testing recommendations to apply. So if the county transmission is high, test new admissions with the series of 3 tests. First being on admission, then again on day 3 and day 5. And residents should be advised to wear source control for 10 days. If the community transmission is not high, new admissions should be tested at the discretion of their facility per CDC guidance. They should be advised to wear source control for their 10 days after admission as well. Any residents who have been out of the facility for longer than 24 hours should be managed as a new admission. The quarantine and testing is not recommended for residents if they have left the facility for less than 24 hours for doctor's appointments, outings, etc. Empiric use of transmission-based precautions may, following a close contact with COVID-19 may be considered if the resident is unable to be tested or wear source control as recommended for the 10 days following their exposure. The resident is moderately or severely immunocompromised, or if the resident is residing on a unit with others who are moderately or severely immunocompromised, or if the resident is residing on a unit experiencing ongoing COVID transmission that is not controlled with initial interventions. If testing does identify a newly confirmed case of COVID-19 in residents or staff, it is recommended to use contact tracing to identify any potentially exposed contacts. Those individuals should be tested with 3 viral tests, and they should maintain source control for any exposed individuals. If all potential contacts are unable to be identified or managed with contact tracing, or if the contact tracing fails to halt transmission, then a broad-based approach should be used. With the broad-based approach, all residents and staff may be tested in the affected area, such as, a group level, such as a unit, floor, building, or it could be facility-wide. In the event that you find evidence of ongoing transmission, the facility should consider implementing quarantine and work restrictions, switch from that contact tracing to the broad-based approach, and also continue testing residents and staff every 3 to 7 days until no new cases are identified for 14 days. Return to work criteria for healthcare professionals with confirmed COVID-19. Healthcare professionals with mild to moderate infection who are not moderately to severely immunocompromised can return to work if at least 7 days have passed since their symptoms started, and the healthcare professional has a negative antigen test within 48 hours of returning to work. They can return to work after 10 days if they are not being tested. If the healthcare professional has severe to critical COVID-19 illness, they can return to work if at least 10 days have passed and up to 20 days since their symptoms appeared, and they have been fever-free for at least 24 hours without the use of any fever-reducing medications, and that their symptoms such as cough or shortness of breath have improved. Healthcare personnel who have or moderately to severely immunocompromised should use a test-based strategy and consult with infectious disease and their occupational health professional to determine when it is best for them to return to work. There are some updated visitation recommendations that state that facilities should provide guidance, such as posted signs at entrances for visitors who have confirmed COVID-19, symptoms of COVID-19, or have had a high-risk exposure to someone with confirmed COVID-19, to defer any non-urgent in-person visitation until they meet criteria to end their isolation. Also, for visitors who've had close contact with someone with COVID-19, it is safest to defer non-urgent in-person visitation until 10 days after their close contact, if they meet criteria described in CDC healthcare guidance. So also in areas where community transmission is high, everyone should wear masks within the facility. In areas where the transmission rate is not high, facilities can choose to not require visitors to wear masks unless there's an outbreak. And with all these recommendations, your policies should reflect that. Do we have any questions?
All right, we'll give people a minute to ask their questions if they have any. You can either submit them using the Q&A tool or the chat in your Zoom menu. And if you would like to audibly ask your question, you can raise your hand and I will unmute you and you can ask your question that way. So we'll give everybody a couple minutes to send us those questions. And while we're waiting, I would like to again remind everyone that next week's webinar, we'll be discussing emergency preparedness planning for nursing homes. That's Wednesday at 2 p.m. And we invite you to join us again next week for that discussion with Penny Imes. If you want to talk further on these topics, but you prefer a one-on-one discussion, we invite you to join us during our office hours, which are every Tuesday at 8 a.m. and every Thursday at 2 p.m. The office hours are kind of like a chat room, but they're live and you can drop by during those times and someone will be on our team will be there to answer your questions. You can find the links to our live chats and our webinars, the newsletter that we send out each Friday called the Last Minute Lowdown. If you would like to receive that newsletter but don't think you're on the mailing list, you can email me and I will get you on the list. My email is caudill@qualityinsights.org and I will drop my email in the chat shortly for you to have that on hand. And I will also be sending out another email to everyone who registered for this webinar later this week with the recording for this webinar and the presentation slides. So you'll be able to get in touch with us that way if you need to. Now let's take a minute. Looks like we might have a question here. So it says to confirm close contact definition. I guess that question's asking what's the definition of close contact?
Yeah, so the definition of a close contact per CDC is any contact where you are closer than 6 feet for longer than 15 minutes. And that can be all at once or consecutively throughout the day. And also any direct, one-on-one contact with someone where you're physically touching.
So we have a clarification. It says, if you are wearing source control as in an N95 or surgical mask, would the close contact definition apply?
If you're wearing source control, yes, it will still apply.
Okay, thank you. So another question says, I just reached out to our contact with HAP regarding PA HON 662, who noted that we are now required to have HCP test on day 5 and day 7 if using an antigen test. And if either is positive, they must stay out for 10 days. Is this correct? And if you'd like, you can pull that question, Jennifer, is in the Q&A if you'd like to read that whole paragraph yourself. That might be easier than me reading it to you.
Okay. Corinne, I will get clarity on this. They are to test on day 5 and day 7. However, I'll get clarity if day 5 is positive and day 7 is not, whether or not they must stay out for 10 days.
All right, yeah, we'll get in touch with you at the email that you registered for this webinar with. Okay, so another question says, is there a recommendation for vaccinated versus unvaccinated for source control? Should unvaccinated staff wear N95s or is a procedure mask sufficient?
Under this new guidance, there's no delineation from vaccinated or unvaccinated. The source control is you can wear either a face mask or a N95 for that one. The universal PPE is a little bit different, which is N95.
Okay, those are some great questions. We'll probably take another minute here to see if anybody else has any questions, but that's all we have so far. You can also raise your hand if you would like to just ask your question if you don't like the chat or the Q&A tool. Okay, so we got another question. So in a nursing home staff, all staff within the contact definition would need to be tested even when wearing a N95 when they have worked around another employee that tested positive.
Yes.
Okay. Again, we'll take another minute in case anybody else has a question. Thank you for all your questions today. Okay, I think that should do it. If anyone had a question that wasn't able to ask today, again, you can email either me or Jennifer Brown. Jennifer's email is jbrown@qualityinsights.org. And as I said before, I will be sending a follow-up email to everyone with the recording for this webinar. So if you didn't catch our email addresses, I will include that on the email. I'll be sending that to the email address that you all registered with. Now, before we sign off, I will real quickly drop our emails in the chat, just in case you need to get in touch with us before that. So there it is. If you look in the chat, you'll find the email for myself and for Jennifer Brown. So if you do need that on hand, you can copy and paste it real quick. But if not, like I said, I'll be sending another follow-up email later this week. And it's been a couple more minutes and we haven't received any other questions. So I will go ahead and wrap this up. Jennifer, did you have any items you wanted to wrap up with real quick that popped in your head?
No, thank you so much, Kathy.
Okay, great. Well, in that case, I'd like to thank you for joining us again, and hope that we can see you all again here again next week. Jennifer, thank you for joining us again.
Thank you. Bye-bye.
Bye.